and opportunities. A variety of different compounds, ligands, can be screened in silico for their ability to fit the receptor. This information facilitates the precise design of drug candidates, with an ideal fit to increase selectivity and a better potential for development success. STARS can also be used to unlock the power of fragment screening for intractable GPCR targets.
So, shall we start now? 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 Now, we have already studied the pharmacokinetic. Now, we will move to the other dimensions of the pharmacology, that is known as pharmacodynamics. So, in pharmacodynamics, what we are studying, that is very important to understand. If you see, when we studied the definitions of the pharmacodynamic, so when we studied the pharmacodynamics in the beginning, in the introductory part of the pharmacology, at that time I have already told you that there is a difference between pharmacokinetic and pharmacodynamic. Now, what is the difference? So in pharmacokinetic, what we have studied? We have studied the absorption, distribution, metabolism, and excretion of the drug. While in case of the uh, we have studied the let me change the layout. So in pharmacodynamics, we have finished the pharmacokinetic. In that, we have studied the absorption, distribution, metabolism, and excretion of the drug. Now, uh, that is regarding the, you can say, the time course of the drug in case of the movement of the drug from the body. Say for example, absorption, that is the first step. This is followed by the systemic distribution, then excretion. So that was about the journey of the drug through the body. That means at what time drug
સર તમારું માઇક મ્યુટ છે.
એવું છે. એક મિનિટ હો. Okay. Pharmacodynamics. So this is the new topics for the pharmacology. We have already finished the pharmacokinetic. In pharmacokinetics, hello, hello. હા આવી ગઈ પહોંચાડી દીધી તો આવી ગઈ. એ આવવાના હશે તો હું મોકલાવી દઈશ, વાંધો નહીં. હો? તો આવવાના હશે તો મોકલાવી પણ દઈશ. So in the pharmacodynamics, किसकी? हाँ हाँ. So in pharmacodynamics, we will study the what we will study. It is a nothing but the physiological and biochemical alteration brought by the drugs and mechanism of action of drug in the body. So in the pharmacodynamics, we will study the mechanism of action of the body, or mechanism of action of the drug. Let me do one. uh, So meaning of the pharmaco means drug, dynamics means power. So how the drug exerts its power on the body. Hello. પેલું ઓફિસે લઈએ આવી ગયા. સારું સારું, હા વાંધો નહીં. હા ના ના અર્જન્ટ કઈ નથી. હા. હમ હમ હમ. ઓકે ઓકે. હા હા હા. Okay, so pharmacodynamics means it's a if you see the plain meaning of the word pharmacodynamic is nothing but the power of the drugs. That means the how the drugs will produce the power by which it produces the therapeutic effect. Now if you look to this power of the drug in terms of what? So it in terms of the it causes the modifications in the existing physiological and biochemical functions, and in this way it will produce the therapeutic effect. Now there is one basic important thing you should keep in mind is that the drug will never initiate any new physiological or biochemical process. It can only and only modified, alter or change the existing biological process. So this thing you should keep in your mind. Drug has no capacity to initiate the new physiological or biochemical process, but it can only and only modify or alter or change the existing physiological and biochemical processes. So what is pharmacodynamic? Pharmacodynamic is nothing but it's a physiological and biochemical changes or alteration caused by the drug, and study of the mechanism of action of the drug in the body, or how the drug affect the animal's body. Already we have discussed this in the pharmacodynamic. Drug is the main actor. આપણે જેને ગુજરાતીમાં કરતા કહીએ છીએ, બરોબર. Drug છે બોડીમાં જઈ અને શું changes કરે છે, that is to be studied in the pharmacodynamics. Very simply, if you want to remember that, it is study of the mechanism of action of the drug, or it is the physiological and biochemical alteration caused by the drug to produce the therapeutic effect, that is known as pharmacodynamics. Now mechanism of drug action, it is of three types. Some drugs act directly on the body and tissue. There are indirect action. Say for example the antibiotic, antifungal drug, antiparasitic drug. They do not act on the body, but they act on the pathogens. They act on the bacteria. They act on the fungus. They act on the parasite. but still they produce the therapeutic effect. That means they are indirectly acting. Then another one is the replacement therapy. That means the hormonal therapy, vitamin supplementation, mineral supplementation, where the hormones which is being produced in the body is being replaced with the synthetic hormones, with the therapeutic agent. So the mechanism of action of the drug is classified into the three main category: direct acting, indirect acting, and replacement therapy. In the direct acting, you can say any drugs which directly act on the body and tissue. Say for example, drugs which are acting through the receptors, alpha receptor, beta receptor, that is stimulant and depression. Then indirect acting and replacement therapy. Now, now this direct action or indirect acting drugs or through the replacement therapy. The direct interaction of the drug with the body or with the cells or with the tissue of the body, they are again classified into the two different mechanisms or two different ways, that is structurally related mechanism and structurally non-related mechanism. Now, structurally non-related mechanisms, the action depends on the physico-chemical property of the drug. Say, for example, if you are having acidity and when you take the ENO, so what ENO will do? ENO contains nothing but it contains the sodium bicarbonate. So, it will neutralize the acid. How? By with the help of by virtue of its physico-chemical property. So, that is structurally unrelated mechanism. Similarly, your activated charcoal will causes the adsorption of the toxin or poisonous material in the gastrointestinal tract. So that is the example of structurally unrelated mechanism. Of structurally related mechanism or structure-based actions, that in that cases the drug interact with the some component of the body which are fixed or which are known as target of the drug, and with the help of this target of the drug or by combination with this drug target, it will initiate the changes or alterations in the existing physiological and biochemical process. Say for example, receptors, then enzymes, then carriers, then ion channels. So what happens there with all these the drug will bind, and they will initiate what? They will initiate nothing but the physiological and biochemical process. They will modify, they will stimulate the receptors, they will inhibit the receptors, they will inhibit the enzymes, they will stimulate the enzymes, they will inhibit the carrier, they will stimulate the carriers, they will close the ion channels, they will open the ion channel. So when the drug combines either with the receptors or enzymes or carriers or ion channels, that will brings the changes in the physiologicals and biochemical activity of the particular cell. So by this way, drug will also act. Now let us see what is the receptor. Now receptors, it's a part of the cell, it's a component of the cell, it's a macromolecules which are present on the cell, inside the cell. That means on the external surface of the cell, inside the cell means in the internal surface of the cell, or many receptors are also distributed through the cell membrane. So these are the macromolecular component of the cells which are present either on the cell, in the cell, or through the cell, which receives the drugs or you can say the which binds with the drugs to produce the therapeutic response. So this is very, you can say, the common definitions of the what we can say uh, receptors. Now here you can see the receptors. What is this? Just a minute. Let me share the another screen. So now visible, are you able to see the receptors on the screen?
Yes, sir.
Ah, so what is this receptor? So these receptors are nothing but they are the macromolecules of the cell, a component of the cell. No, it's a one kind, one part of the cell. They are located either on the cell, in the cells, or through the cells. Now let us see the different characteristic of the receptor. Receptors are also interacted by the natural endogenous substance like neurotransmitters. So you have already studied in your nervous system, central nervous system, autonomic nervous system. There are many neurotransmitters, say for example acetylcholine, adrenaline, which combine with the adrenergic receptors or cholinergic receptors. So these receptors has a capacity to combine with the endogenous substance, and these endogenous substance which combines with the receptors, they are known as ligand. They are known as what? They are known as ligand. Okay. There are receptors for the hormone also. You might have known the estrogen receptor, progesterone receptor, oxytocin receptors, androgen receptors, testosterone receptors. There are receptors for the many endogenous compounds like histamines, 5-hydroxytryptamines, then cytokines, then interleukins, and all these things. So receptors, it's a very, you can say, the widely distributed throughout the cell. It has capacity to interact with the endogenous substance like neurotransmitters, hormones, autopoids, and other substances. So by this, I want to say you that these receptors are not only and only meant for the interaction with the drug. They will also interact with the different kinds of the molecules. Now the drugs interact with the receptors and produce their effect by either stimulating or suppressing the ongoing cellular process. This is this drug. Now drug, what it do, it interact with the receptors. Drug combines with the receptors and produce the effect either by stimulating or suppressing the ongoing cellular process. Now drug once combined with the receptors, so these combinations will activate the series of the process. Will activate the series of the process. There may be activations or there may be inhibitions depending upon the nature of the receptors and the pharmacological property of the drug. The natural drug receptors are mostly enzyme located in the cell membrane. The interaction between drug and this receptor produce either a direct effect on the cell or an indirect effect through the activating or promoting the synthesis or release of the another intracellular regulatory molecules called as second messenger. Now, when the receptor combined with the drugs, what will happen? It activate or inhibit the certain enzymes, and which in turn means this activation or inhibitions of these enzymes subsequently will produce the direct effect or indirect effect. Now, this activation of these enzymes will promote the synthesis of the second messenger like cyclic AMD, the cyclic GMP. So, this second messenger will act as a will modify the cellular functions, will modify the existing biological and physiological functions. Now, the direct effect of the receptors include the alterations in the activity of transmembrane enzymes, ion channels, then G protein coupled receptors. The second messenger, that is cyclic GMP and cyclic AMP, include the stimulations or inhibitions of adenine cyclase for synthesis of the cyclic AMP and guanyl cyclase. So, what is receptors? That is important thing. Pelli vastu, it's a component of the cell. It's a macromolecules of the cell. Where it located? They are located on the cells, in the cells, or through the cells, or they are embedded in the cell membrane. To whom it will interact? The receptor can interact with the endogenous molecules like neurotransmitters, hormones, autocoins, and many other substances which are present in the body. Apart from this, it has capacity to interact with the drugs. So when drug combines with the receptors, it will initiate the series of the biochemical process. There may be stimulations of the certain enzymes. There may be inhibitions of the certain enzymes depending upon the configurations of the drug and receptors complexes. Now, if the enzymes is activated, then there may be say increase in the synthesis of the cyclic AMP, cyclic GMP. So that we will come in the later part of the discussion. So this is the basic concept of the receptors. Now, if you see, the enzymes. Now what is enzymes? Now enzymes is nothing but the what you can say the now, and some drugs, instead of acting on the receptors, they directly act on the enzyme. Say, for example, the best example is the paracetamol, diclofenac, meloxicam. These are the drugs. They are having analgesic, antipyretic, and you can say the anti-inflammatory activity. Now, these drugs combines with the enzymes and inhibit this enzyme known as cyclooxygenase. Now, this cyclooxygenase is important, play important role in the synthesis of the inflammatory mediators. So this non-steroidal anti-inflammatory drug, especially paracetamols, then this diclofenac and all these things, they will inhibit the enzyme cyclooxygenase. Now this cyclooxygenase inhibitions will reduce the synthesis of the inflammatory mediator. So it will produce the anti-inflammatory activity. Are you clear? Enzyme inhibitions, best example is non-steroidal anti-inflammatory drug, that is paracetamol. What it does, this paracetamol causes the inhibitions of the enzyme cyclooxygenase. Now, this cyclooxygenase is involved in the productions of the inflammatory mediators. So, if this enzyme is inhibited, then there is no production of inflammatory mediators. And if there is no production of inflammatory mediators, then there will be no question of any inflammation, fevers, or you can say the pain. Another example is the neostigmine. It inhibits the acetylcholine esterase enzyme. Now, this acetylcholine esterase enzyme is responsible for hydrolysis of the neurotransmitter, that is acetylcholine, which is hydrolyzed into the acetic acid and choline esterase enzyme. So that you will learn in the autonomic nervous system. Now another one is the false substrate. Drug act as a false substrate. False substrate એટલે say for example methyl dopa. Dopamine is there inside the body. That is dopamine is an endogenous ligand which is has capacity to bind with the receptor. ડ્રગ ડોપામિન જેવો ને જેવો સબસ્ટન્સ કયો છે મિથાઇલ ડોપા એમાં ખાલી આપણે મિથાઇલ ગ્રુપ મૂક્યું છે એટલે બે સિમિલર છે એમ ડોપામિન અને મિથાઇલ ડોપામ બહારથી તમે જો તો ઓલમોસ્ટ ઇટ લુક્સ સિમિલર બટ they are having the chemical differences because this methyl group is added, so that is known as false substrate. Now if you put the methyl dopa and dopamine together into the body, if you put the methyl dopa and dopamine together into the body, what will happen? The enzymes is not able to recognize the, you can say the dopamine. Enzyme is not able to recognize the dopamine. So what happens that instead of dopamine, the enzyme will recognize the methyl dopa. So dopamine is not hydrolyzed, the concentration of dopamine will continuously increase. So this is the, you can say the utilizations of the enzyme by drugs. So false substrate, drug act as a false substrate. That say for example methyl dopa, dopamine is converted into the norepinephrine, act as a neurotransmitter with an enzyme dopamine alpha oxidase. Now in some disease more concentration of dopamine is required, so drug methyl dopa is given. This methyl dopa act as a false substrate. When enzyme acts on it, it is converted into the methyl norepinephrine or methyl beta norepinephrine. So this is the, you can say the example of the structural analog or false substrate. શું થાય છે સે ફોર એક્ઝામ્પલ આપણે એક્ઝામ્પલ લઈએ પાર્કિન્સન્સ. તો પાર્કિન્સન્સ કેમ થાય છે કે ડોપામિનની ડેફિશિયન્સીથી થાય છે. આપણે પાર્કિન્સન્સની ટ્રીટમેન્ટ કરવી હોય તો શું કરવું જોઈએ? ડોપામિનનું કોન્સન્ટ્રેશન વધારવું જોઈએ. એના માટે આપણે શું કરશું કે ડોપામિન નહીં પણ ડોપામિન જેવું મિથાઇલ ડોપા એ ડ્રગ છે આપણે પેશન્ટને આપશું તો શું થશે બોડીમાં જશે એટલે એનો જે ડોપામિનમાંથી નોરએપિનેફ્રિનમાં જે કન્વર્ઝન થાય છે વિથ ધ હેલ્પ ઓફ ધ એન્ઝાઇમ ડોપામિન આલ્ફા ઓક્સિડેઝ, બરોબર? તો એ ડોપામિન આલ્ફા ઓક્સિડેઝ એન્ઝાઇમ્સ છે એ ડોપામિનને પછી રેકોગ્નાઇઝ નહીં કરે, ડાયરેક્ટ કોને રેકોગ્નાઇઝ કરશે? મિથાઇલ ડોપામિન. કારણ કે બંનેની સ્ટ્રક્ચર છે સેમ જ છે, ખાલી આમાં મિથાઇલ ડોપા વધારાનું છે. એમ છતાં ડોપામિન આલ્ફા ઓક્સિડેઝ છે મિથાઇલ ડોપાને રેકોગ્નાઇઝ કરશે એટલે મિથાઇલ ડોપાનું કન્વર્ઝન થશે, ડોપામિનનું કન્વર્ઝન થશે નહીં. ડોપામિન એઝ સચ એવું ને એવું રહેશે. કેવું? એને કોઈ મેટાબોલિઝમ કે કોઈ હાઇડ્રોલિસિસ થશે નહીં. એટલે there will be a increased concentrations of the dopamine and this is required for the treatment of the Parkinson's disease. So this is the use of the false substrate in the treatment of the disease. Now carriers, these are the molecules responsible for transport of the big substance. Now the drug may produce its mechanism of action by acting, by inhibiting the carriers or by stimulating the carrier. The cell molecules responsible. Now what is carrier? Carrier is nothing but the molecules which are present in the cell, which are responsible for transporting the some important substance from one place to other place through the cell membrane. Say for example, carriers for the amino acid, carriers for the glucose, carriers for the many peptides, carriers for the hormones, carriers for the enzymes. So these are the molecules which makes the movement of the different endogenous substance from one place to other place through or across the cell membrane. Now the many drugs will bind with this carrier. Many drugs will bind with this carrier and it inhibits the functions or stimulates the functions. Say for example, furosemide. Now furosemide is a diuretic. Now what is diuretic? Diuretics are the drugs which increase the frequency of the urination. Frequency of the urination. So furosemide acts as a diuretic, that means it increases the urinary volume. It is given in case of the anuria. Anuria means there is a complete cessation of the urine. કોઈને પેશાબ ન આવતો હોય એને આપણે anuria કહીએ છીએ. તો આવા કેસમાં આપણે furosemide આપીએ છીએ. It what it will do now? It acts on sodium carrier and inhibits it. Now these diuretics, this furosemide inhibit the sodium ion carrier. So there will be no, you can say, the reabsorptions of the sodium from the nephrons to the blood circulation. So concentrations of the sodium will increase in the lumen of the nephrons and this ultimately increase the water content and thereby it increase the volume of the urine. Another example of the drugs which interferes with the carrier molecule is the hemicolium. It's a toxic molecule present in the some you can say the venoms. Now these hemicoliums inhibit the transport of the choline that you will learn in your autonomic nervous system classes. Hence, it stops the formations of acetylcholine. So in this way, drug interfere with the enzyme, drug interfere with the carriers, and the last option we will see is the ion channels. Now, what is this ion channel? Drug directly interact with the ion channels and modulate the transport of the ions through the channel. First, પહેલા તો તમને એ ખબર હોવી જોઈએ કે what is ion channel. Cell membrane, you everybody knows this. From this cell membrane, there are many protein channels which crosses this cell membrane. That is a special mechanism of transportation between internal and external environment of the cell. So these ion channels, many times drugs binds with these ion channels or you can say drug binds with the gate of the ion channels. Those channels will get activated, so it will open, it will allow the entry of the specific ion, not all the ion. If it is a calcium channels, then only calcium can enter. If it is a sodium channel, then only sodium ions can move in and out of this channel. So this is, you can say, the ion channels. The drugs either directly interact with the ion channels, either they modulate the activity or opening and closing of the ion channels or movement of the ions through the ion channels, and in this way they will produce the therapeutic effect. The best example is the local anesthetic. Local anesthetic, that means that if you apply the anesthetic on skin, it will get, you can say, the insensitive. So how it produce the insensitivity or loss of the sensitivity from particular area? It blocks the sodium channels in the neurons. The sensitivity is caused by the neurons, and neurons in the neurons there is a channel, sodium channel. If this sodium channel is blocked, then there is influx and outflux of the sodium, potassium, or other ions will be lost, and there will be no excitability. And if there is no excitability, there is no generations of the impulses, and if there is no generations of impulses, then there is no question of transportation of the impulses from one place to other place. So whatever pain sensations you are giving in the anesthetized area, that will not reach to the brain. So this is the blockage of the sodium channels by the local anesthetic. Clear? Then another one is the amyloride, that is a diuretic. It blocks the channels of the sodium channel for the reaction. Then virampil and diltiazem, they are the calcium channel blocker. So these are the, you can say, the different types of the ion channels which are involved in the functions of the drug. Now, before going into the details, let me show you some important aspect of the receptors and all these things. Now, here you can just listen.
There are four types of receptors: ligand-gated receptor.
There are total four types of the receptors. Number one, ligand-gated receptors, that already I have told you. Then enzyme link receptors, that modulate the activity of the enzyme. Then third one is the G protein coupled receptors, and fourth one is the intracellular receptors.
Receptors have specific site to bind to molecules.
Now here you can see the receptors. They are located either on the cell membrane. Are
Or
you able to
ligand.
see the video?
This is called.
Hello.
Yes, sir.
So receptors are located on the cell membrane. That means the receptors are located here also, here on the cell membrane, or inside the cell membrane also, or through the cell membrane. This is the example. Here the receptors are located throughout the length of the cell membrane. Some part is outside of the cell membrane, some part is embedded in the cell membrane, and some part is inside of the cell membrane. So that is the, you can say, the receptor. Now every receptor has the binding site, and to this binding site the endogenous substance will bind. So here you can say this is a binding site, and this is the ligand. Ligands may be neurotransmitters, it may be hormones, it may be anything else which is present or occupied in your body. They all are called as ligands. So this ligands binds with the binding site, and these bindings will activate the receptors, and because of that there is a initiations of series of the biochemicals and physiological process in the cytosol, and that will lead to the therapeutic response. So clear?
Called a lock and key
Here
model.
you can see when the ligand binds, there is a activation of the receptors.
In ligand-gated receptors, the cell membrane requires specific ligand-gated channels for movement of hydrophilic molecules through it. First, ligand binds to the receptor, then the receptor gate opens. For example, acetylcholine binding to nicotinic receptors. In this example, sodium enters the cell and electrochemical gradient is created, resulting in depolarization. In enzyme-linked receptor, the transmembrane protein of the receptor are enzymes, or closely associated with enzyme. For example, tyrosine kinase receptor. The binding of the ligand induces dimerization of the receptor, which activates its tyrosine kinase activity through autophosphorylation and phosphorylates other intracellular enzymes sequentially. The phosphorylation status of the enzyme in this example is to the receptor, then the receptor gate through it. First, in ligand-gated receptors, bind to molecules
general structure of the receptors. Then if it
or
binds,
ligand. This is
then
called
there is the
a
activations
lock
of
and
the
key
receptors,
model.
and these activated receptors
In
will cause
ligand-gated
the
receptors,
changes in the physiological receptor. Now first, ligand-gated ion channels. That is the example of the first channel. So what is ion channel? Ion channel is nothing but it's a channels made up of the protein. This is a proteins. This is a channel, and this is the cell membrane. So some specific ion, if it is a sodium channel, then sodium ion can move here and through. If it is a potassium channel, then potassium ion can move here and through. If it is a calcium channel, then it will allow the movement of the calcium. If it is a you can say the other channels. So in this way, these are the some ion specific channels which is present in the cell membrane. So that is known as ion channel. Now how it will function? Now here you can see that ligands or drugs binds with
the cell membrane requires specific ligand-gated channels
so
for movement of
this will
hydrophilic
bind with
molecules through it.
this receptors or
First,
ligand gated
ligand
channel. Here
binds
you
to the
can see the
receptor,
binding is
then the
going on. Now
receptor gate
once it will
opens.
bind
For
and this channel has opened, you have seen now this channel is open. Now
example,
open for whom?
acetylcholine
If this is
binding
a
to
sodium
nicotinic
channel, so
receptors.
sodium will
In
able
this
to
example,
enter
sodium
into the
enters the
cell
cell
membrane.
and
Now,
electrochemical
once the sodium enters into the cell membrane, that means there is an increase in the positive charge inside the cell. That means that is hyperpolarization. That means there is a excitability increase in the cell. So in this way, the drugs when combined with the ligand gated receptors or you can say the ligand gated ion channels, it will produce the response. Now let us go
gradient is
further.
created, resulting in depolarization. In enzyme-linked
Now
receptors,
this is the example of the enzyme linked drug receptors. So these are the you can say the receptors and this is the enzyme. This is the enzyme. Now these ligands, this ball like structure will bind here and because of their binding there is activations of the enzymes and these activations will causes the phosphorylation of this enzyme that is known as tyrosine kinase. Now, this phosphorylated tyrosine kinase will initiate the further series of the biochemical and physiological or biochemical reaction in the cells. It may stimulate the protein synthesis, it may stimulate the glucose synthesis. So, that is our pharmacological response. Now, let us see.
the
Here you
transmembrane
can
protein
see
of the
these
receptor
ligands
are
will come here.
enzymes, or closely associated with enzyme. For example, tyrosine kinase receptor. The
Here you
binding
see
of the
now ligand
ligand
binds with
induces
the receptor.
dimerization of the
There is a
receptor,
locking,
which
then this
activates
ATP
its
will be
tyrosine
activated.
kinase activity through autophosphorylation and phosphorylates other intracellular enzymes sequentially. The phosphorylation status of the enzyme may result in activation or inactivation, resulting in various cellular responses. With the gene-protein coupled receptor, first the ligand binds
Now
to the
this is the
receptor.
third G protein coupled receptors. So how this is a you can say the G protein. This is 3 units of the alpha, beta, and delta. Now these ligands will combine with the
Which
G
causes
protein.
structural
So
changes in
there
the
will be
receptor,
activations of the receptor, and because of
and
that,
in
this
turn
alpha
changes the
subunit will
shape
get
of the G
separated.
protein, which
It will
reduces
combine here with
GTP
effector
to
protein.
GDP. This leads to the separation of the alpha
Alpha
subunit from
subunit
beta
will
and
get
gamma
separated. It will
units.
combine with the
This
effector
in
proteins,
turn
and it will
activates other
stimulate the effector
enzymes
proteins.
and effector proteins. Intracellular
And this is the
receptor.
intracellular receptors. Already you are doing.
Ligands that pass through the cell membrane
Here you can see
enter
the
the
ligands
cell
will
and
enter
into the
into the cell
nucleus,
membrane.
crossing the
It will
nuclear
cross the
membrane.
nuclear membrane
After
and
entering
combine
the
with the
nucleus, the
intracellular
ligand
or
binds to
intranuclear
the
membrane.
intracellular
These
receptor.
receptors.
This can
Example is
alter
this
the
steroid
transcription
receptor.
of DNA within a cell.
That will increase the synthesis of the DNA and RNA. So this is the basic concept of the what you can say the drug receptors. Now uh, now you can see now the binding of the receptor to the drug is very crucial process. Clear? Are you getting my screen on your mobile? Drug binding to receptors. Binding of the drug receptor take place through the following physicochemical interaction. Is it visible to you?
Yes, sir.
Okay. Now we have seen the different types of the receptors. We have seen the how it interacts. This is general. Okay. We have seen this plain receptors, then enzyme link receptors, then you can say the ion channel. Now, the binding between the drug and receptors is mediated through the ionic force, through the hydrogen bonding, through the hydrophobic interaction, through the van der Waals force, covalent bending. Now, if you look to the, if you have studied the chemistry well in the 11th and 12th, so which one is the most strong bond out of these five? So it is naturally that it is covalent bonding, where the valency is shared between two molecules, between two atoms. So there will be the greater attachment. It is a something you can say the something like permanent bonding. So because of that, if the drug binds with the receptors with the covalent bonding, then duration of action is prolonged. Why? Because the covalent bonding, the attraction force is very, you can say, the strong. So naturally, the drug and receptor will not dissociate it very easily or very fastly. Ionic force again weak, hydrogen bonding again weak, hydrophobic interaction that is again it is very weak. Van der Waals force to somewhat stronger, but the most strongest one is the covalent binding. Here you can see the van der Waals bond, ionic bond, hydrogen bonds are weaker bonds and are easily breakables and reversible. So in this case, the action of the drug, if the drug binds with the receptor with ionic force or hydrogen bonding or van der Waals force, the interaction between receptors is of weak in nature, is of reversible in nature. Okay, so the, the drug action is temporary, it is for the short duration of time. But in case of the covalent bond, the association between the or binding between the drug and receptor is stronger. So the action is of longer durations and it is irreversible also. Now, difference between specific receptors and non-specific receptors. Difference between specific receptors and non-specific receptors. For specific receptor, the minor change in the molecular structure of the drug causes the major change in the pharmacological response. Because non-specific receptors have very low specificity for chemical structure requirement. So there is no need to you just keep that point. Now, drug action and effect. This is very important to understand. What is the difference between drug action and drug effect? Paracetamol, if you take the paracetamol, it will reduce the body temperature, it will reduce the pain, it will reduce the fever. So, all which you are able to observe, reduction in the body temperature, reduction in the pain, these are known as drug effect. These are known as drug effect. So, then what is drug action? How paracetamol reduce the body temperature, how paracetamol reduce the pain. So it inhibits the cyclooxygenase enzyme, it reduces the synthesis of the inflammatory mediators and thereby reduce the body temperature and thereby reduce the fever and thereby reduce the pain. So that is known as drug action. That means how drug act on the body, that is pharmacodynamic. How drug act, whether it is inhibiting the enzyme, whether it is combining the receptor, whether it is combining the ion channel, whether it is combining with the G protein. So that is known as drug action. So drug action is defined as the method or manner or ways by which the drug influence the cell function, or it is the methods, manners or ways by which the drug produce the or drug causes the alterations in the cell function. એટલે very simple drug action કેવી રીતના કામ કરે છે એને drug action કહેવાય. drug નું કામ કર્યા પછી કેવી આપણને અસર જોવા મળે છે એને drug effect કહેવાય. Very simple, there is no need of being confused. Drug effect or pharmacological effect or response is the result of the drug action on cellular process. Penicillin on microbe or aspirin on headache or pain. Example, penicillin interfere with the, that already I have explained you. Penicillin તમે લેશો તો શું થશે, બેક્ટેરિયલ ઇન્ફેક્શન જતું રહેશે, એ તમારી ડ્રગ ઇફેક્ટ થઈ, તમને તાવ મટી જશે, તમને ગેસ્ટ્રોએન્ટેરિટિસ મટી જાય, એ ડ્રગ ઇફેક્ટ. પણ એની એક્શન શું છે? It inhibits the microorganism by inhibiting the synthesis of the cell wall. That is known as action. and causes the lysis of the death. That is the effect. So this is the drug action and drug effect. Now drug receptor interaction. Let us try to see the drug receptor interaction. Now this drug combined with the receptors, it forms the drug receptor complex, and this complex stimulate the series of the biochemical process, and which ultimately lead to the drug effect or pharmacological effect. Now, classifications of the receptor. This is a basic theory of the drug receptor concept. The drug combines with the receptors, it will form the drug receptor complex, and this drug receptor complex will initiate the series of the biochemical changes, and this will lead to the pharmacological action and effect. Now, the classifications of the receptors. There are four type of the receptor: G protein coupled receptor, kinase coupled receptor, ion channel receptors, and steroid receptor. Already, I have shown you the uh, video. What is G proteins? Remember G proteins, they are a transmembrane protein. Transmembrane, that means that the protein runs through that cell membrane. That is known as transmembrane. They are embedded in the membrane. Their one end is in extracellular part and other end is in the intracellular part. So they are known as transmembrane. So G proteins are nothing but they are transmembrane protein present on the cell membrane. It linked with the guanine nucleotides, so they are known as G protein coupled receptors. They have heptamer structures and are serpentine in shape. Already we have seen, and it is discovered by the Goodman, Alfred G. Goodman and Gutenberg. The spelling mistake is there. Hmm. Now these are the membrane-bound receptors which mediate the action through the guanidine nucleotide. There are many types of the G proteins like G stimulatory, G inhibitory, GO protein, GQ protein, G13 protein. So there are many types of the G proteins. આપણે interest શેમાં છે? G protein coupled receptors. What is G protein? They are transmembrane protein. They are linked with the guanine nucleotide. That's why they are called as G protein. They are heptamers, and they are serpentine in nature, discovered by the Goodman and Gilman. Now, these membrane-bound receptors which mediate the action through the guanidine nucleotide. There are many types of the G proteins. Now, kinase coupled receptor. Already, I have shown you the that clip. Kinase, tyrosine kinase. It's a enzyme, and when the receptor drug combined with the receptor, there is activations of the tyrosine kinase, and these tyrosine activations will lead to the, you can say, the many biochemical actions. So another is the ion channel coupled receptors. Hmm? Say for example, this insulin receptors, they are tyrosine kinase receptors. Then similarly, ion channel GABA receptor, nicotinic receptors, they are glutamate receptors, they are ion channel receptors. Steroid receptors, glucocorticoid receptor, mineral corticoid receptor, they are uh, located in the nucleus. So this is, you can say, the basic concept of the receptors. Now, theory of the drug action, how drug receptor interactions will occur. हाँ बोलो.
सर बीच सर ने मुझे सर को फोन किया कि एक प्रिंटर आपके डिपार्टमेंट से नीचे लेना है, मुझे सर ने बोला एक ले जाओ, तो कौन सा?
जरूर ले जाओ. Now theories of the drug actions. Now we have, what is receptors already discussed. What are the different types of the receptors? We have already discussed. What is the force of attraction between the drug and receptors? That also discussed. What is reversible? What is irreversible? What is drug action? What is drug effect? So that is clear about the receptor. Now let us see the how the interaction between drug and receptors will take place. The theory of the drug action. The drug receptor interaction as the base of drug-induced effect give rise to the different theory of the drug action. Now, number one, drug receptor theory. There are different types of the there are many scientists who have proposed the. સાહેબ તમારી thesis આવી ગઈ જો હાલો હમણાં મોકલાવું એક લેક્ચર પતે ને એટલે ના ના એ મારે આઈટી માં પડી છે બસ 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 ઓર્ડર કાઢી નાખો ને અંદાજ મોકલી દીધો શનિવારે આ બોલા આજે બોલા જનક કે રવિ જવાનો જ છે ડેરી સાયન્સ વાળો હા તો હું હમણાં મોકલાવું હા 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 Now, theory of the drug action. ચિંતન મોદી સાહેબ આવ્યા હોય ને તો એમને મારી થીસીસ એક આવી હશે લઈ આવી ને ડીવી મોદી અને શક્ય હોય ને તો ચૌહાણ સાહેબ ને આપવાની છે માઇક્રોબાયોલોજી એટલું કરી નાખે અર્જન્ટમાં Now, theory of the drug action. Now, first theory. આ theory of the drug action એટલે શું છે કે ડ્રગ અને રિસેપ્ટર વચ્ચે કેવી ઇન્ટરેક્શન થાય છે કે અલગ અલગ સાયન્ટિસ્ટે અલગ અલગ થિયરી આપી છે અને અલગ અલગ આપણને જેને કે કન્સેપ્ટ આપ્યા છે તો પહેલો કન્સેપ્ટ છે કોણે આપ્યો ફર્સ્ટ કન્સેપ્ટ વોઝ ગિવન બાય ધી J.N. Langley in the year of the 1878. Now, the receptor concept of the drug action was first proposed by the Paul Ehrlich and subsequently by the J.N. Langley. Now, what this concept says, what this theory says, each drug acts on its matching receptors, which is structure specific to produce the pharmacological response. That means, according to this theory says that each drug had specific receptor, each drug had separate receptor with which this drug interact. That means just like enzyme and substrate. એક ડ્રગ માટે એક રિસેપ્ટર બીજા ડ્રગ માટે બીજા રિસેપ્ટર that means specific receptor is there. So all the drugs have different receptors. Hello. Hello. બોલો તમે ક્યાં પહોંચ્યા હા તમે આવીને મને ફોન કરજો તો હું અહીંયા જ છું આખો દિવસ. So according to this theory, all the drugs have different receptors. One type of drug will not react with the receptors of another type. That means specific drug, specific receptor, pair, uniform pair. A combined with A only, B combined with B only. A cannot combine with B, B cannot combine with B. That means specific drug, specific receptor. So all the drugs have the specific receptor. So this is the base of this drug receptor theory. That means it is something like lock and key model of the enzyme and substrate. જેમ particular key can open particular lock બરોબર એ તમે ભણી ગયા છો. That means the noradrenaline receptors can only interact with the adrenergic receptor. Acetylcholine can only interact with the acetylcholine receptor. Oxytocin can only interact with the oxytocin receptor. Growth hormone cannot interact with the oxytocin receptor, or oxytocin cannot interact with the growth hormone receptor. So this is known as specificity theory or drug receptor specific interaction theory. Now, the second theory, occupancy theory, that is proposed by the A.J. Clark in 1936. That is after, you can say, the 60 or 50 years of the first theory. First theory was proposed by 1878. So, after 50 years of that is after 5 decades, another scientist, A.J. Clark, who proposed the occupancy theory. Now, this occupancy theory, according to this theory, the pharmacology or drug response is directly proportional to the portion of the receptors occupied by the drug. Very simple to understand occupancy theory. The drug response is directly proportional to the fraction of the receptor occupied by the drug. That means if 100% receptor is occupied, then drug response is maximum. If 50% receptor is occupied, then drug response will be 50%. If 10% receptors are occupied by the drug, that means the drug effect will be 10%. Number of receptors occupied by the drug is directly proportional to the response. So maximum response is observed when all the receptors are occupied. Very simple to understand. There is nothing to complicate. There is nothing confusion. When you will find the maximum response when all the receptors are occupied, that will produce the maximum response. Now, what is the drawback of this theory? This theory could not explain the phenomena that partial agonists occupy full population of the receptor but fails to elicit the maximum response. Now, this is very important to understand. First, you should try to understand what is agonist. Agonist એટલે શું? The substance which combines with the receptors and is able to produce the physiological response are known as agonists. Say for example, we will take the examples of the adrenergic receptors. Adrenergic receptor ની સાથે adrenaline જોડાય એટલે એ receptor નું stimulation થાય એટલે heartbeat વધે, blood pressure વધે, blood નું constriction થાય. તો એ adrenaline ને શું કહેવાય? agonist. એટલે favorable stimulatory effect આપે. તો એની જગ્યાએ ધારો કે એડ્રીનલ રિસેપ્ટર ઉપર એટ્રોપિન મૂકો અથવા બીજો કોઈ સબસ્ટન્સ જોડાય તો શું થશે? રિસેપ્ટરનું સ્ટિમ્યુલેશન થશે નહીં અને ઘણી વખત એની ઇનિબિટરી ઇફેક્ટ અથવા ઓપોઝિટ ઇફેક્ટ આવશે. તો ધેટ સબસ્ટન્સ ઇઝ નોન એઝ એન્ટાગોનિસ્ટ. One is agonist, another is antagonist. Agonists are again classified into the full agonist and partial agonist. પાર્શિયલ એગોનિસ્ટ એટલે કેવું છે કે રિસેપ્ટર સાથે ડ્રગ જોડાય પણ તમને ફૂલ રિસ્પોન્સ ના મળે. બ્લડ પ્રેશર વધવું જોઈએ તો એટલું ના વધે, હાર્ટ રેટ સ્ટિમ્યુલેટ થવા દે એ સ્ટિમ્યુલેટ ના થાય. તો ધેટ ઇઝ નોન એઝ પાર્શિયલ એગોનિસ્ટ. Partial agonist will combine with the receptor but not able to produce the maximum response. So that is this theory, the occupancy theory જે ખોટી પાડે છે કે ભાઈ પાર્શિયલ એગોનિસ્ટ જે છે એ રિસેપ્ટર સાથે કમ્બાઈન થાય જ છે અને બધા રિસેપ્ટર સાથે કમ્બાઈન થાય છે છતાં આપણને મેક્સિમમ રિસ્પોન્સ મળતો નથી. So this statement or these problems was not so, you can say, covered by the occupancy theory. Then another one is the Stephenson theory. Now Stephenson in 1956, again after 20 years, 25 years, the Stephenson coined the term efficacy. He given the term efficacy. So what is efficacy? Efficacy is defined as the ability of the drug to produce the response. So what is efficacy according to Stephenson? It is the ability of the drug to produce the response. That means the drug is able to combine with the receptor. પણ રિસ્પોન્સ ઉત્પન્ન ના કરીએ તો શું કરવાનું? એનું ખાલી કોમ્બિનેશન કરીને કરવાનું શું? So what is efficacy? Efficacy is nothing but it's the ability of the drug to produce the response. Drug receptor સાથે combine થાય છે અને response produce કરે છે. That is known as efficacy. Now according to the Stephenson in the 1956 he has given this theory, and according to his theory highly efficacious drug produce the maximum response even though they have combined with the small fractions of the receptors. Now Stephenson को clear कर कह रहे हैं कि भाई the highly efficacious drug, that means the most efficacious drugs produce the maximum response though they will combine with the small fractions of the receptors. એટલે એવું જરૂરી નથી કે મેક્સિમમ રિસ્પોન્સ પ્રોડ્યુસ કરવા માટે 100% રિસેપ્ટર ની સાથે ડ્રગ ને જોડાવવું જોઈએ. 5%, 10%, 20% ડ્રગ પણ જો રિસેપ્ટર સાથે જોડાય તો પણ મેક્સિમમ રિસ્પોન્સ મળે છે. આ પણ શરત એટલી કે એ ડ્રગ કેવું હોવું જોઈએ? ઇટ મસ્ટ બી હાઈલી એફિકેસિયસ ડ્રગ. ઇટ મસ્ટ બી ફુલ્લી એફિકેસિયસ ડ્રગ. Clear? Then fourth one is the rate theory. Now rate theory, that is WDM Patton proposed in 1950. This is the name of the scientist who has proposed this theory in the 1950s. Now according to this rate theory, the drug response is directly proportional to the drug receptor complexation. The drug response is determined by the rate at which the drug combines with the receptors and leaves the receptor. Now you see, we have seen the one equations in the beginning. That what is drug and receptor? So according to this pattern theory પ્રમાણે drug અને receptor જેટલા ઝડપથી combine થાય અને જેટલા ઝડપથી છૂટા પડે reverse direction માં, બરોબર, બંને વચ્ચે equilibrium છે એમ માની લ્યો. જેટલા ઝડપથી combine ને જેટલા ઝડપથી છૂટા થાય એ rate, એ speed જેટલી વધારે એટલું drug નો response maximum. It's very simple, no need to confuse. The drug response is directly proportional to the drug receptor complexation, or drug response is determined, or it is directly proportional to the rate at which the drug combines with the receptors and the rate at which the drug leaves with from the drug receptor complex. That means આ બંને drug અને receptor વચ્ચેનું union થાય અને છૂટા પડે, ભેગા થાય અને છૂટા પડે, એ પ્રોસેસ નો રેટ જેટલો વધારે એટલું ડ્રગ નો રિસ્પોન્સ વધારે. That means the greater the rate of the associations and dissociations of the drug and receptors, greater will be the intensity of the response. Greater is the response. Now antagonist combine with the receptor at faster rate but dissociate it at very slower rate. That's why it is not able to produce the acid. College માં જ છું. The antagonist, it combines with the receptor at the faster rate, but the dissociation of the antagonist from the receptor is very slower. So combining is faster, dissociation or is slower. So that's why the antagonist is not able to produce the required degree of the response. And because of that reason, it is classified as an antagonist. Then the fifth one is the drug-induced protein change theory. It's a change. There is a spelling mistake. Drug-induced protein change theory. Now, drug-induced protein change theory, that means drug causes the temporarily changes in the structure of the receptors and makes it active. And these active receptors will produce the drug response. Then the last theory, that is two-state receptor theory. Now this receptor theory, according to this, the agonist combined with the site on the receptors and the receptor becomes activated and produce the response. When drug leaves, the receptor returns to the non-activated state. That means the two-state receptor, the receptors are activated and receptors are inactivated or non-activated. When they are activated, when the drug combines with the receptor, and they will produce the response. When they are the drug leaves these receptors, so receptors are non-activated or inactivated. So this is the two-state receptor theory. Now principles of the drug action. Before that, let me see the some. Are you able to see the PPT now? Classifications of the receptors. Hello.
Yes, sir.
Okay. So this is what already we have discussed it. हाँ चिंतन. हाँ. એવું છે એમ. સારું સારું. So this we have already, I have explained you all these things, enzymes, uracemide, structure activity relationship. Now the principles of the drug action. So we have studied the definitions of the pharmacokinetic, then what is receptors, then what are the different targets, the direct, indirect, enzymes and carriers and all these things, then types of the receptors, then the force or interaction between the receptor, that is ionic, hydrogen bonding, hydrophobic, then different theories of the drug receptor complex and different types of the receptors. So the pharmacological response. Then another one is the drug efficacy. The maximum effect a drug can produce, which depends on both drug affinity and intrinsic activity. Then agonist. You have to simply remember the affinity means it is ability drug receptor સાથે જોડાઈ શકે એની ability ને આપણે drug affinity કહીએ છીએ અને જોડાણા પછી એ response પેદા કરી શકે એને efficacy કહીએ છીએ. Intrinsic activity છે drug ની પોતાની inherent inbuilt capacity છે એ drug response ઉત્પન્ન કરી શકે છે. Then agonist, already I have explained you, the agonist is a drug that interact with its receptors and produce the positive effect. It has both affinity and efficacy. That is isoproterenol, histamine and morphine. Agonist એટલે તમારે એવું યાદ રાખવાનું કે કોઈ પણ કેમિકલ્સ છે એ રિસેપ્ટર સાથે જોડાય અને સ્ટિમ્યુલેશન જોવા મળે અથવા પોઝિટિવ ઇફેક્ટ જોવા મળે તેને agonist કહેવાય. If the drug combines with the alpha adrenergic receptors and produce the stimulations of the adrenergic receptor, then that drug is known as agonist. If drug combines with the adrenergic receptors and it inhibits the adrenergic receptor, then it is known as antagonist. Now, full agonist, agonist which is able to produce maximum response. If it is partial agonist, then agonist which is able to produce partial response, not maximum response. So that is partial agonist. Then antagonist, already I have explained you. Now, partial agonist, the antagonist having some effect similar to the agonist is called as partial agonist. An agonist is fully participate in the drug action effect sequence, whereas the antagonist has only action, drug action. Agonist has affinity and efficacy, while the antagonist has only affinity and efficacy. Now, this is very important to understand. You see, an agonist fully participate in the drug action effect sequence. That means the agonist will combine with the receptors, it will produce the pharmacological response, it will produce the pharmacological effect, where antagonist has only action. Antagonist only combine with the receptor but not able to produce any effect, not able to produce any pharmacological effect. So this is the difference between agonist and antagonist. Agonist શું કરે છે receptor સાથે combine થાય છે, receptor ને stimulate કરે છે અને pharmacological action આપણને જોવા મળે છે. Antagonist શું કરે છે receptor સાથે combine થાય છે but it is not able to produce the pharmacological action. So this is the difference between the agonist and antagonist. Okay, now agonist has the affinity and efficacy. બરોબર, agonist ની પાસે affinity એટલે it can combine with the receptor. receptor ની સાથે તો એ જોડાય જ છે અને જોડાણા પછી એ પાછું drug response પણ ઉત્પન્ન કરે છે. That means agonist has both as affinity as well as efficacy. Well, antagonist has only affinity, not efficacy. Antagonist has only affinity, not efficacy. This is a little bit confused, but if you read once again, you will revise it from the textbook or from the your class note, then definitely it will be you are able to understand it. Now, value of the intrinsic activity, that is for full agonist, that is produce the maximum response, the value is 1. Antagonist, it is 0. Partial agonist, it is greater than 0 but less than 1. Inverse agonist, that is 0 to -1. So this is the, you can say the agonist, antagonist, partial agonist and efficacy and you can say the affinity. Very simple. Affinity એટલે binding ability, efficacy એટલે pharmacological effect ઉત્પન્ન કરવાની capacity, agonist એટલે full potential તમને receptor stimulation જોવા મળે એને agonist કહેવાય. બરોબર, ફૂલ રિસ્પોન્સ જોવા મળે તેને ફૂલ એગોનિસ્ટ કહેવાય, અડધો રિસ્પોન્સ જોવા મળે તેને પાર્શિયલ એગોનિસ્ટ કહેવાય. એન્ટાગોનિસ્ટ છે રિસેપ્ટર સાથે કમ્બાઇન થાય પણ ફાર્માકોલોજીકલ ઇફેક્ટ જોવા મળે નહીં. પાર્શિયલ એગોનિસ્ટ ઓલરેડી નાઉ ધ નોન રિસેપ્ટર મીડિએટેડ ડ્રગ એક્શન. અત્યાર સુધી આપણે જે જોયું that is the direct actions of the drug through the receptors on the body, but there are certain drugs which do not act through the receptor. Say for example, મેં તમને સવારમાં એક્ઝામ્પલ આપ્યું હતું ઇનો સોડિયમ બાયકાર્બોનેટ which neutralize the gastric acid in the stomach and will produce the antacid effect. Okay. Similarly, activated charcoal, similarly your liquid paraffin, similarly your sodium bicarbonate, aluminum hydroxide. So there are so many drugs which do not interact through the receptor, osmotic diuretic, osmotic purgatives, which do not require the response, but by the virtue of their physico-chemical property, they interact with the substance in the body and they will produce the pharmacological effect. So such drugs are classified as a non-receptor mediated drug action. ઇનો શું કરે છે? સોડિયમ બાયકાર્બોનેટ તમારે ગેસ્ટ્રિક એચસીએલ સાથે કમ્બાઈન સોલ્ટ અને પાણી બનાવે છે એટલે એસિડ છે એ ડિસેપિયર થઈ જાય ને એસિડ પીએચ છે એ થોડી વધે એટલે આપણને જે પેટમાં બળતરા થતી હોય ખાટા ઓટકાર આવતા એ બંધ થઈ જાય. બરોબર. એક્ટિવેટેડ ચારકોલ છે તો ઇટ વિલ પિક અપ ઓર ઇટ વિલ એબ્સોર્બ, it will attract the poisonous material from the gastrointestinal tract and prevent the absorption. એટલે પોઈઝનિંગ માં એનો ઉપયોગ થાય છે. તો આવા ઘણા બધા એક્ઝામ્પલ્સ છે. હલો. So this is, you can say, all about the drug receptor interaction. Tomorrow we will see the dose response curves and all these things. We will stop the here. There are a lot of things. ઘણું બધું તમને શીખવાડવાનું બાકી છે. So let me. Okay.